we'll be looking at how we can just improve the cervical cancer screening for eligible women on ART, specifically at Chilonga Mission. So I invite you to listen in and to ensure that you are attentive so that you can be able to make this discussion rich. We looking forward to your comments and to just see how Chilonga Mission did, whether it's the root cause analysis, how the justification of the problem, and things like that. So we want your comments. Please use the chat box or indeed raise your hand when we begin our discussion. Farrai is going to have about 10 to 15 minutes to power through this presentation, and then she'll be able to summarize this case presentation at the end. Farrai, are you ready to start?
Yes, I am.
Okay, so I think without further ado, we will start this presentation. Thank you.
Good afternoon. This is Farrai Paradza presenting from Chilonga Mission General Hospital. So we are presenting on our QA project entitled Improving Cervical Cancer Screening for Eligible Women on ART at Chilonga Mission General Hospital. Our project started on the 1st of April 2023, so it's ongoing. It's a project of the duration of 1 year, 5 months. So Chilonga Mission General Hospital is located in Pika district of Muchinga province. And then we established our cervical cancer clinic in 2021, where we started screening women, with all women, particularly women living with HIV/AIDS. So in 2021, we screened about 502 women, which gave us a percentage of 62%, which we realized that it's below the national standard of 95%. So we embarked on this journey to increase the screening rates for women living with HIV. So our target, we wanted our target to reach as far as 95% as of September 30th, 2024, from 63%. So our mission for the project was to provide cervical cancer to all provide cervical cancer screening to all HIV positive women at Chilonga Mission General Hospital. Our vision was for a stable and productive quality of life free from cervical cancer in women living with HIV. And our goal was to increase the coverage in cervical cancer screening to women living with HIV positive from the current 62% to 95% by September 2024 at Chilonga Mission General Hospital. So our performance statement, or rather performance expected standard, is at 95% of women to be screened. Desired performance is still at 95%, and actual performance when we started the project was at 62%, giving us a performance gap of 33%. So our performance gap statement is 33% of women living with HIV to be screened at Chilonga Mission General Hospital. Okay. So our numerator for our project was the number of eligible women on ART to be screened for cervical cancer. Our denominator is the number of women on ART eligible for cervical cancer screening. We had our in-house meeting where we established that 33% of these women were not screened, which is our performance gap. So this meeting helped us to realize that we had a gap that we needed to fill up by following up these women in the community to screen them so as to increase our performance to 95%. So we came up with root cause analysis using the fishbone diagram. So this is what we came up with. These are the problems that we came up with under the root cause analysis. So we realized that we as a clinic were not engaging the health promotion officers and also the community health workers in the awareness of cervical screening in the community. And we also realized that we were not prioritizing these women when it came to screening for cervical cancer. We just screen for everybody, all the women, not really prioritizing to say we need to target these women. We never used to have, we didn't have review meetings to monitor and evaluate these programs, and also a lack of structured schedules owing to work overload. So we also didn't have resources to do our outreach programs where we are supposed to go out there in the community to sensitize and do awareness for cervical cancer and also screen these women. So we came up with a prioritization matrix where we put up problems that we faced as we went out in the community. So we had cultural beliefs, low outreach services, and also low turnout. So on the cultural beliefs and the low outreach services, outranked the other problems that we had. So we came up with interventions on how we are going to, So we came up with interventions on how we are going to come up with these, on how we are going to work out these problems. So on the cultural beliefs, we realized we integrated the cervical cancer with other promotion activities. For example, under 5 clinics and also viral load whenever we go out to bleed our clients, and also for when we have under 5 programs, because that is when a lot of women come out to do the under 5 program. So we integrated it with under 5 programs, where we would also come out and sensitize and also screen these women. Then we also sensitized through radio programs using a cervical cancer champion, where we went to a radio station with a cervical cancer champion to just help us to just give us a testimony of what happened to her when we diagnosed her with cervical cancer up to the time that she was declared cured. And also we involved the influential leaders and the community health workers together with SMAGs in the awareness of cervical cancer screening. So on the low outreach activities, we decided to start planning, with the help of our partners, Right to Care, CHA and CHAS. We managed to go out for outreach programs, outreach services to screen these women, and also managed to prioritize cervical cancer activities. So, and then we started coming up with a list of women that are due for cervical cancer screening, who are receiving HIV, who are on ART treatment. Yes, so, and also we integrated the cervical cancer program with other programs like the MC, the VO coverage, and the other 5 clinic. So looking at our data, so after we did all these interventions, we realized that women were able to come to the clinic, and whenever we go there, we'd find that there's a huge number of women waiting for us to screen. That is after we did our sensitization. We also integrated our cervical cancer. After integrating our cervical cancer with other programs, there was an increased number of women coming to this to the facility, and whenever we go out there, we still find that the community health workers have arranged, or rather have brought all the women together at the clinic for us to screen. So when we also involved the SMAGs and the village headmen and also the churches, at least the numbers were convincing people would go out there and find these women waiting. And then, and we also managed to conduct our outreach programs with the help of Right to Care and CHI. So now looking at our data presentation, you'd find that there's an improvement from the time we started. Oh, sorry, it was supposed to start with April, not September. That was an error on our part. Okay, so looking at our graph, we're able to see that there was an increase from 72%, rather 68%, 63 to 95 to this month, last month, right, in August 2024. So when you look at February, March, and April, you find that the numbers are static. So this is because this was a farming period. So women would go to their fields early in the morning and come back a bit late. So you'd find that even when we do the awarenesses, no results were much yielded. Yeah, so for February, March, and April, there's 82 on all of the 3 months because of the farming periods that were there. But afterwards, we managed to see a rise in the cervical cancer screening from May, June, July, and August. Has been an increase. Yes, so because of the interventions that we had put in place, we managed to see an increase up to 95% in August. Okay, so during this whole program, we managed to learn a few things, that is prioritizing women living with HIV for screening. Yeah, we would come up with a list of women under ART or on ART, and then manage to put out dates on when next they're going to screen. So we managed to come up with a list, and then we are now able to follow up these women in the community with the help of our partners. And also, whenever we find a cervical cancer positive woman, treated, cured, everything done for her, we're able to bring them back as testimonies to the other women out there. Because whenever you go out in the facilities, you find that there are these myths and conceptions from people. So with the help of these women that have undergone the screening, that have undergone the cervical cancer management and everything, you'd find that these women are encouraged out there, and then they're able to come to the clinic to ask questions and also to be screened. And also sensitization. When we go out there for sensitization, we don't only sensitize women, but also men on the importance of male circumcision, because we all know where the HPV virus is mainly found. So, and also we managed to learn that whenever we do an in-house data review, we're able to come up with, we're able to know where we are in terms of data. We're able to know our gaps and how we can come up, or rather how we can cover up the gaps that we have. So for the recommendations, we are able to, with the help of the awareness, we say the cervical cancer champion, we're able to have at least women coming to the clinic because they have a testimony of what happened to someone. They're able to come, maybe they have questions and maybe they want to be screened. They're able to come to the clinic. And also with the help of data review meetings, we're able to see our gaps and how we can improve. And also we managed to conduct, or rather by conducting a survey on the myths and misconceptions that are there in the community, we're able to know where we're lagging behind and how best we can help these women out there in the communities. So that's all for the recommendation and the lessons learned. On the data sources, we got our data from the ART Smart Care, Cervical Cancer Register, and the HMIA tool. Okay, so would like to acknowledge the MOH, the help of the MOH, the Provincial Health Office, JPIGO, Right to Care, CHA, and CHARS for their help throughout this project from last year to date. Okay, so yeah, so this is a question to the group on what other strategies that can be used here at our hospital that can help us to sustain more positive gains in the screening of cervical cancer. Thank you so much. I submit.
Thank you so much, Farrai, from Chilonga Mission Hospital. I think your presentation was quite clear. Are you able to just go through the summary, especially for the people that might have joined in a little late? Farrai, can you get me? Farrai?
It appears they are muted. I can see
I think proceed.
Okay, Farrai, if you are muted, if you were speaking while muted, kindly unmute.
Oh, okay, sorry. I'm using someone else's phone, so I think I'm muting you. I muted everybody.
Right. Yeah, I was just saying, are you able to just go through a summary of this case presentation from your hospital for the benefit of those that may have joined a little late?
Oh, okay. So the project that we're doing is the project title that we are focusing on is improving cervical cancer screening for eligible women on ART at Chilonga Mission General Hospital. So so our mission was to provide cervical cancer screening to HIV positive women at Chilonga Mission General Hospital. Our vision is for a stable and productive quality of life free from cervical cancer in women living with HIV. So our goal was to increase the coverage in cervical cancer to women living with HIV from the current 62 to 95 by September 2024 at Chilonga. So the 62% is what we started with when we started the project. So the 95 is the national standard that we were aiming to reach by this month. So the gap was at 33%. So that is the gap that we're trying to cover during this whole project. So our expected standard is at 95. So, but the performance gap is 33%. So this is the gap that I'm talking about that we need to cover as we're doing this project. So we came up with a root cause analysis of the fishbone diagram, which is this. These are the problems that we faced as we are doing the project. So we managed to sample out a few using the list of root causes that we came up with that are also on the fishbone analysis. So these are some of the root causes. Some are poor planning, fear of the unknown among the recipient of care because of the myths and misconceptions out there in the community, and also lack of review meetings to monitor and evaluate the program strategies. So this is our prioritization matrix where we prioritize the cultural beliefs and law outreach programs for our project. These are the main problems that we encountered as we were screening these women. So these are the interventions on how best we thought we would counteract the root causes. So for the cultural beliefs, we said we sensitized through radio programs using a cervical cancer champion, where we involved a cervical cancer champion who explained her ordeal as she went through the treatment of cervical cancer, and also integrating cervical cancer activities with other health promotion activities like Under 5 and MC, and also involving influential leaders in the community like the headman, the chiefs, and also also involving the churches to help out in the sensitization and the awareness of cervical cancer in the communities. And then for the law outreach activities, we learned that we had to prioritize our cervical cancer activities. We had to prioritize our cervical cancer activities and also to integrate again with the other health programs. So this was our performance tracking using the same root causes. These are the interventions that we came up with and observed change that we experienced after we did the interventions. And this was our graph, a data presentation. That is from the time we started the project till last month, August 2024. So like I explained, we had a static percentage of 82% from February to April here because of the farming period, where women would go for farming and come back maybe in the evening, or just come back after a month when they are done with their farming. So that is why we find that these 3 months were a bit static. So after this, we continue to see a rise. Like as of May, June, July, and August, we managed to see a rise in our percentage rate up to 95% of last month. So these were our recommendations and the lessons that we learned as we did the project. So where we said we're going to be prioritizing these women with HIV for cervical cancer screening, which we are doing and still ongoing, and also using testimonies from cervical screened women that helps to debunk the myths and misconceptions that are there in the communities, and also integrating with other projects like Under 5 and MC or Viral Load. And then the recommendations were with the awareness, with the cervical cancer champion that will help alleviate these myths and misconceptions that are there in the community. We felt that if someone who's undergone this whole thing, the whole ordeal of cervical cancer, would just open up and tell the others of what really transpired and what happened, people out there would come and get screened. And also to conduct data review meetings, which has been very helpful, and also conduct a survey of myths and misconceptions on cervical cancer screening services, which is still ongoing. So I think that's the summary we can give.
Thank you so much, Farrai. It has been a good presentation, very clear. And thank you so much, Team Chilonga Mission Hospital. Team, we have heard the presentation, and Chilonga Mission has a question. You know, they covered a gap, about 33% gap. Currently, they stand at 30% from 60%. Their question is, what other strategies can be used in Mission General Hospital to sustain the positive gains in cancer screening? So you can see the issue now for them is not reaching 95%, but they are looking for strategies of how to sustain this positive gain that they've got in cervical cancer screening. And so we are looking forward to having some interactions with you folks. Do we have any comments, general comments from anyone? I see a hand, Gertrude N. Silungwe. Please unmute and go ahead.
Thank you, Chair, and thank you very much, Chilonga Mission Hospital, for the beautiful presentation. So I wanted to find out on since you asked a question on what other strategies you would embark on to keep the 33% gap. Have all the women been contacted, even those who went out in the fields? And if so, have they been allocated to, I noticed that you are working with the SMAGs, which is a good thing. So can we say 100% of all the women that you had targeted have been contacted and follow-ups will be done to keep this gap? And then secondly, I wanted to find out if the hospital offers a full range of treatment or you have services which you need to refer, and how far or how accessible are the facilities? Thank you. Over there.
Thank you so much, Gertrude. Gertrude there. Can we take one more question? Gertrude had asked 2 questions. Can we take one more question before Chilonga Mission can be able to, can see a hand, Clevinah Mizinda. Please unmute.
Thank you so much. I could have missed it in the presentation regarding the collaboration with the surrounding health facilities, taking into consideration that Chilonga is a hospital that receives also referred cases from the other facilities. So my suggestion would be, I don't know if this is a question or a suggestion, to say they need to collaborate. What other strategy can they use? They need to strengthen collaboration with the surrounding facilities that do refer cases to them, so that even as they go back to their catchment area or to their areas after being discharged, they should go with the message to encourage others to go for screening. I submit. Thank you, Chair.
Thank you so much, Clevinah. So Farrai Chilonga Mission Hospital, are you able to respond to some of those queries that have been raised?
Yes. So for the first question, where they asked about whether we are able to, what kind of services we're able to offer. Here the treatment that we have when we find that someone has the lesion, we do LEAP. But for those that we suspect of query ICC, we refer to SAC. We get a biopsy sent to Chinsali, where we have a pathologist there, and then when the results are positive, or if the query ICC has been confirmed, then refer them to SAC, CDH. Then for the other question about the other women that if at all we followed them up, yes, we did. So after they came back from the field works and everything, we managed to follow them up with the help of the community health workers. Yes. Sorry, I've forgotten the third question.
I think the one from Clevinah was really a comment for you in terms of strengthening. You should be able to collaborate with other players in the space. We've got a hand from Oscar Malakata.
Yeah, thank you very much, Chair. That was a very good presentation from Chilonga Mission General Hospital. I was just interested to find out from the presenter or the team from Chilonga Mission Hospital if they've devised a system at any given day, somebody walks into the hospital, do they have a system to showcase how many women from the TX are eligible for cervical cancer screening? This is from the background that we realize even when we are using smart care, there is no late to cervical cancer screening report generated by smart care. If we look in the cervical cancer screening register, there's no provision for writing ART numbers, so that working in collaboration with the SEERs, they should be able to enter the ART numbers, be able to showcase whether the women are eligible or not. So any system to that effect, so that we can learn from them, because they really did very well with respect to this QI presentation. And of the presentation, I think one of the challenges that we may be facing in other provinces is the cervical cancer treatment coverage for the clients that test VIA positive. How are we doing, even if it's not part of your presentation, with respect to ensure that we improve treatment of the women that are VIA positive? Are we having a demand-driven service provision, or do we have specific days as a hospital when treatment is offered to clients with positive VIA? I submit. Thank you.
Thank you so much, Mr. Oscar. Clevinah, you can tackle those questions before we attend to the ones in the chat box. Sorry, Farrai.
Oh, thank you so much. For the one where we are able to monitor who is due and who is not, for that one, for sure, even in smart care and the registers that we have as cervical cancer, there's no provision. So what we normally require or request from our clients is whenever they come to the clinic, they come with a card, the cervical cancer card. From wherever they were screened from, they have to come. It's a must. They have to come with a card where we are able to assess or check before attending to them. We check if at all they are due or not. I think, yeah. And we normally place community health workers at all entry points to try and capture every woman that comes through each and every entry point. I think that has really helped us as a hospital. So for smart care and for the registers, for sure there's no provision. So even if we were to generate a list, it doesn't really help as such. So I think that whenever we request for cards, that whenever they come to the clinic, they come with cards, and then we're able to check when and where, when they were tested and when they are due.
Thank you so much. We'll read one question from the chat box, and then we'll get back. I can see your hand, Alex Ngulube. Just kindly hold that thought. Lucas Tembo is asking, are we also using HPV as a screening modality? Because WHO requires us to use a high performance test, which is HPV. Farrai?
Yes, we are also using HPV whenever we are provided for by our partners. But in a situation where we do not have, we just go ahead and do the VIA.
Are these situations more often than not? Do you usually have the HPV or you don't usually have it?
We don't usually have the HPVs, so mostly we use the VIA.
All right, Lucas, if you have any reservations, you can type in the chat box and we'll get to your comment. Alex Ngulube.
Thank you very much, Chair, for the opportunity. Am I audible?
Yes, loud and clear.
Thank you, Chair. So it's an amazing picture to see how Chilonga Mission has really closed the gap of 33% from last year, September, up to as of now, where they are above 95. That's a beauty. Maybe I want to learn 2 or 3 things on how they're doing it for them to achieve that, if at all that is applying. The first issue is how are you working then with the faith leaders in terms of creating demand for those women in those faith organizations? The second question is that do you have a day or a specific day when you conduct these services at the facility, or there are some specific days, so to say? Then the last one is that for those women who are outside your coverage area and that they are due, though they're eligible for a cervical cancer screening, how then are you reaching out to them for you to provide that service? Or is there a modality that is working for you, especially for those women who are working or are living outside the catchment area, especially during the rain season, where some women, even if they're eligible, they could be traveling maybe to go their farms or fields. So how are you handling such issues as Chilonga, if at all that is arising? Thank you so much. I submit.
Thank you so much, Alex. Farrai, and then we'll take D. Sashi as the last hand before we can delve into the presentation by Dr. Chaila. Farrai?
Thank you so much. For the clinic, we don't have specific days when we screen. We screen Mondays to Friday. It's an everyday situation. So we open our clinic at 8 and close at 16. So it's every day. Then for those that are outside our coverage and those that normally maybe go in the fields and so for those that go out in the fields, we just engage this community health workers to assist us in organizing as soon as they are back, so that we conduct either an outreach, considering where they're staying, we conduct an outreach program, or they come here where we are able to screen them. Thank you.
Right, D. Sashi.
Thank you so very much, Chair. Am I audible?
Yes, you are audible.
Okay, great. So, good presentation. I raised my hand because I'm looking at the phone and it might fall off anytime soon. That was a very good presentation, and I just have a few comments. To start with, I observed from the presentation that the baseline was 62 and the target is 95. But what was reflected in the effect, which is the fishbone, was 68. Maybe, I don't know if that was just a typo, meaning that if that is the case, in the effects of the fifth-born, which we normally say the standard is that we always want to put a performance gap, which is the 33%, which will highlight the problem at hand. Okay, so I thought that I should bring it down. Then my other concern is regarding the graph, which is the time period. And I say so because looking at the questions that they have asked, Chilonga has asked in terms of the strategies, my question now goes to Chilonga to say, have you dived into just analyze why there was so many variation in terms of the graph? I could see there were some which were quite high. Have you gone deeper to analyze what is it that you were doing to bring that graph from maybe where it was 68 to 70? We may be asking other strategies, and yet we actually have an answer at hand. So I would want them to really dive in the analysis of why there are those variations in the month, because the graph kept on rising if you have observed. Yeah, so maybe they may just comment there. Then the last one is on the performance tracking. I've also noted that as they were writing the outcomes, some of the outcomes were not reflecting to the activities or the processes that they had indicated. For instance, where they were talking about is it number of screens. So the outcome should be a change, like the first one which they highlighted. Unfortunately, I couldn't see. I'm unable to look at it, but I saw the first outcome came out very good. But the second one, they just indicated the cervical cancer, of which maybe something has to be done from there. So Chair, I submit those are the comments I have. Thank you.
Thank you for the feedback, D. Sashi. We have another presentation by Dr. Chaila that we will get into, but Chilonga Mission and Farrai do take keen interest in the chat box. Very busy. There are a number of strategies that people have listed. Time allowing, we will come back to read them out. For now, we will now switch over to Dr. Chaila's presentation. Please do listen in, but in the meantime, Chilonga Mission, you can go ahead and address some of the concerns or some of the questions that have been put down in the chat box. Dr. Chaila, are you ready to do the presentation from your end?
Yes, I am. I'll be sharing shortly.
So while Dr. Chaila is doing his sharing his presentation, Farrai and the team, please do take note. There's comments from Beauty Mudenda. We have Brad B, Masao Sobanda, Mulea, and a number of other comments in the chat box. So please do look at them. Dr. Chaila, I can see you've shared your presentation. Please go ahead.
Thank you so much, Dr. Muhuma, and good afternoon, everyone. And as introduced, Mwate Joseph Chaila is my name. I'm the Deputy Chief of Party for Health Services, currently working with the USAID Zambia Accessible Markets for Health project, which is being implemented by John Snow Health. We do realize that last week we had another presentation on cervical cancer, which was provided by Dr. Kamfa, the National Coordinator for Cervical Cancer Control. The focus was on the programmatic aspect of cervical cancer screening, but this week our focus is on improving cervical cancer screening for HIV positive women. So we will start different today. I will go straight into the poll. As you can see, we have even termed it revision poll question 1, because this is information that was shared with us last week. I'll ask the admin to run the poll for us for this question, so that we just see if there are any gaps after last week's presentation, and hopefully by the end of this presentation, we'll be able to cover them. Dr. Muhuma.
All right, thank you so much, Dr. Chaila. A very good way to start the presentation. Our first question, before I launch it, let me just read it out and then I'll launch it. Revision for question 1. What are the 2 most prevalent types of HPV that cause 70% of cervical cancer worldwide? What are the 2 most prevalent types of HPV that cause 70% of cervical cancer worldwide? The question has been launched. We can poll in. So those that were starting to use the chat box, please just look on your screens. You have the interaction box for you to be able to answer. Is it A, 6 and 11? Is it B, 11 and 16? Or is it C, 16 and 18? Or indeed D, C, 66 and 18, sorry. So those using the chat box, please use the quiz box on your screen. You should be able to see the question that has been launched. For question 1, what are the 2 most prevalent types of HPV that cause 70% of cervical cancer worldwide? This is a single choice. 6 and 11, 11 and 16, 16 and 18, 6 and 18. We will allow about 10 to 15 seconds for people to poll in. Interesting. Okay, we will end the poll here, having over half the people polling in. We'll share the results. Dr. Chaila, the majority think that C is the answer, 75%, and we have some that think B is the answer, and 4% apiece think that A or D are the answers. I'm sure your presentation will make the answer much more clear. Dr. Chaila, over to you.
Yes, it will certainly do. You can move on to the next 2 polls as well. Then we'll go into the didactic presentation.
Okay. You can just move the... So we'll go to poll question number 2. This is a revision poll question. Single choice. How many years does it take for women with weakened immune systems, such as those with untreated HIV infection, to develop cervical cancer following the infection with HPV? Is it 1 to 2 years? Is it 5 to 10 years? Or is it C, 15 to 20 years? Or indeed 20 to 30 years? The answers are coming in thick and fast, like this. How many years does it take for women with a weakened immune systems, such as those with untreated HIV infection, to develop cervical cancer following the infection with HPV? 1 to 2 years, 5 to 10 years, 15 to 20 years, or 20 to 30 years? We will end the poll here, having over 50% polling in. Sharing the results just now. As can be seen, Dr. Joseph, 56% think that it's 5 to 10 years. We have a significant number, 33%, that think 1 to 2 years is the answer, and 10% think that it's 15 to 20 years, and the last one being 1% thinking that it's 20 to 30 years. So we will go to poll question number 3. Poll question number 3 has been launched. What is the current recommendation by WHO as the primary screening tests and treatment approaches among both the general pop of women and women living with HIV? Understand the question? What is the current recommendation by WHO as the primary screening test and treatment approach among both the general population of women and women living with HIV? VIA and VILI, HPV DNA, cytology, colposcopy. What is the current recommendation by WHO as the primary screening test and treatment approach among both the general population of women and women living with HIV? VIA and VILI, HPV DNA, cytology, or colposcopy? We will end the poll here, share the results. Interestingly, this is a single choice, by the way, so the majority, 63%, think that it's HPV DNA. While we have 31% that go with VIA, and a small minority thinking that it's either colposcopy or cytology. Stop sharing, and I think now, Dr. Chaila, you can take us into the presentation. Thank you for the revision poll questions.
Yeah, thank you so much, Dr. Muhuma. Yeah, and just key highlights from last week's presentation. I think we all know that cervical cancer is caused by persistent infection with HPV. Then also we're told that there are over 100 types of HPV, of which could be classified as high risk or low risk. And we were told that it is the high risk persistent infection, the high risk HPV that may lead to cervical cancer. And also, we were informed that type 16 and 18, these cause nearly 70% of all cervical cancer cases that we record globally. And this aligns with the majority, the 75% who indeed indicated that type 16 and 18 cause the majority of cervical cancer. As we go down the presentation, we will know that the high risk HPV types combined cause over 99% of all cervical cancer cases. Then briefly, the 90-70-90 strategy was highlighted last week, and we were told that this aims to eliminate cervical cancer as a public health concern within the next century. And deep down the presentation will speak to this. So the learning objectives for today's session, we're in this week now, is to understand the increased risk of cervical cancer in women that are living with HIV. And you saw the emphasis from the Chilonga presentation on why they were focused on this particular population, and that is the focus of this week's presentation. Then also we'll deeply go into detail to just look at the HPV and its associated condition, slightly more details than we were last week, and also go a bit into detail in understanding the 90-70 elimination goal. Then finally, which is the focus of today's presentation, we'll also look at how QI projects are important in improving and sustaining cervical cancer screening coverage. We saw the Chilonga example, and as we go down, I will give you another example, primarily focusing on sustainability. This is to remind us on where we are as a country with regards to cervical cancer. This information is as of 2022 from the Global CAN. We saw that as of 2022, Zambia was recording slightly over 15,000 new cancer cases every year, with women being more affected. We had about 6,400 men and close to 9,000 women that reported cancer. And when we look at both sexes, the top leading cancers, when we rank them, we see that cervical cancer tops when we combine both cases. Then also we look at Kaposi sarcoma as well as prostate becoming more important. But when we look on the right of the slide, we will see now by incidence as well as mortality, where we see that cervical cancer remains the biggest cancer that we have in the country, with an incidence rate of about 71.5 per 100,000 women. And also we see that about 49 over 100,000 mortalities are recorded. Roughly, it's about almost 2/3 of women that are diagnosed with cancer die. And we begin to see that in other cancers like breast cancer, this ratio goes to about 50%. And when we look at esophageal cancer, it is almost 100%. Yes, so coming to cervical cancer, which is the topic of discussion today, we see that this is the biggest problem in terms of cancer that we have as a country. We are going to launch now our first official poll question on women living with HIV with regards to cancer. Dr. Muhuma, over to you.
Thank you so much, Dr. Chaila. Remember that the ones we were looking at were just re-poll. So now we get into the polls for today. So we launched the first one. Single choice. What are the two most prevalent types of HPV that cause 70% of cervical cancer worldwide?
Dr. Muhuma, we polled the...
Sorry, we did this. Okay, yeah. Sorry. This we also did. Okay.
Maybe come back to these polls. We hadn't realized that there were more than one set of polls in the presentation.
Right. Okay. Yeah. So, Dr. Chaila, that's a word from our IT.
Yeah, sure.
If you could come back to these questions just a little bit later when they've loaded these questions. Please go ahead with the presentation.
Sure. Thank you so much. The team, you can type the answers in the chat box. Yeah. So proceeding with the presentation, we did highlight that we have 4 objectives. Objective 1, we want to focus on why women living with HIV at increased risk. We wanted to start with a cross-sectional study that was done by faces that you know, Professor Paham, Professor Mizinda. Yeah, so this was a study that was done in 2004, just prior to Zambia activating the cervical cancer screening program. And basically, they wanted to look at the prevalence and predictors of squamous epithelial lesions of the cervix in HIV-infected women in Lusaka, Zambia. Yes, so it was a study involving 150 women that were living with HIV and HPV testing, as well as cytology, were the method that was used to screen these women. Remember, in 2004, VIA had not yet been initiated in the country. Then what was seen was that 85% of the women living with HIV that were screened had high risk HPV infection, meaning that this group was at risk of developing cervical cancer if not treated. Then also what was seen was 76% had a squamous interepithelial lesion, meaning about 114 over 150 had a risk of developing cervical cancer if they were not treated. As you can see from the graph or the pie chart on your right, we had about 19% where it was suggestive of cancer. And we see that only 6% of these cervixes were normal. Thus, this is what gave birth to the cervical cancer program as we know it today. And when the team at that particular time wanted to develop a cancer program, a cervical cancer prevention program, of course, a lot of issues were looked at. And at that particular time, the country felt that VIA was much, much easier for us to implement, given the cost of HPV at that particular time, as well as the complexities of doing cytology. The graph on your right shows another study that was done to just look at cervical cancer or the prevalence of cervical cancer in a group of women. And you see that the red that represents women that were HIV positive, the green represents women that were HIV negative, and the blue, it is the women whose HIV status was unknown. From this graph, especially on women that were living with HIV, we see that there was a lot of cancer compared to the other subpopulation of women that were HIV negative or did not know their HIV status. And also when we look at the distribution of the cases, we see that in women that were living with HIV, there was a peak between 30 to about 45 years of age compared to women that did not know their HIV status, or those that had a negative status where we didn't see any peaks with regards to cervical cancer. And therefore, literature has shown that women that are living with HIV are about 6 times more likely to develop cervical cancer, as we can see from the graph. And as such, as a country, we opted for VIA screening, and now I've started integrating HPV. I've now integrated HPV testing For VIA, we are screening women that are living with HIV once every 2 years and 3 years for those that are HIV negative. Then for HPV, we'll be screening once every 3 years for women that are HIV positive, and for 5 years for those that are not living with HIV. And we will focus on the age group 15 to 49 years as a country. This is a slide that you saw last week from Dr. Kampa's presentation. Basically, it just shows that we have an increased incidence of HPV infection around the age of 15. And this is because this is when most of our adolescent girls start becoming sexually active. As you know, cervical cancer screening is spread. HPV infection is usually sexually transmitted. Then after exposure to HPV infection, we see that the majority of women actually get rid of this infection using their immune system. Then about 15 to 20 years, that's when we begin to see precancerous lesions, and about 20 years from the first time women are exposed to HPV infection, we begin to see cervical cancer cases developing. However, this pathway is disturbed when a woman is immunocompromised, and hence we see that the majority of women that are living with HIV actually develop cervical cancer within 5 to 10 years after they are exposed to a high-risk HPV virus. And this comes to our revision poll number 2, where the majority, slightly over 50%, did indicate that 5 to 10 years. We had about 33% that indicated 1 to 2 years, but it takes about 5 to almost a decade for a woman living with HIV for them to develop precancerous lesions and eventually develop cancer. This slide is just meant to link cervical cancer and HIV. As indicated, is the issue of immunosuppression that weakens the immune system, and thus making it difficult for the natural immune system to get rid of the HPV infection. Then the HPV infection itself brings about the link because it is seen to thrive when the immune system is compromised. Then also HIV-related immunosuppression has been noted to cause chronic inflammation around the cervix, and thus makes it easier for the HPV infection to thrive in such an environment, and eventually it leads to cancerous cells. Then also, I think this is similar to the point above where we are saying compromised cervical health, meaning the cervix tends to get severe dysplasia, especially when there's HIV infection. Then also, though not related basically to the science, but we can see that maybe challenges in the system, barriers for our women accessing regular screening can also can contribute to them developing cervical cancer, especially when we talked about their reduced time or the history of developing cervical cancer, which is much less compared to those that are immunocompetent. So these are some of the factors that can lead, that predispose women that are living with HIV to developing more cervical cancer. This slide you saw last week, basically it just shows from a normal cervix, to a cervix that may have HPV infection, to a cervix that has precancer cells, to actual cancer. But what is important to note is that from normal cervix to precancer, this progress is reversible. We can always reverse and go back to the normal cervix at any point. But once it becomes a cancer, that process cannot be reversed. And as such, the woman will need to undergo treatment depending on at what stage we find them. Then kindly note that a normal cervix, a cervix can appear normal even if it has got HPV infection, and therefore this contributes to why HPV testing is the gold standard for cervical cancer screening. We will move to the second objective, where we are talking about HPV and its associated conditions. IT, I don't know if the 4 questions are ready, or we can just cruise through.
The 4 questions are now ready.
Okay, thank you, Dr. Muhuma, over to you.
Okay, thank you so much, Dr. Chaila and IT. So let me just allow me to launch the second poll question. The second poll question, which of the following cancers are also caused by HPV? Which of the following cancers are also caused by human papilloma virus, HPV? Single choice, is it anal cancer, or B, oropharyngeal cancer, or is it C, penile cancer, or indeed D, or the above? Which of the following cancers are also caused by human papilloma virus? Anal cancer, oropharyngeal cancer, penile cancer, all of the above. We have about 10 to 15 seconds to poll. Read it one last time and then we close the poll. Which of the following cancers are also caused by HPV? Anal cancers, oropharyngeal cancer, penile cancer, or the above? We will end the poll here. Dr. Chaila, the majority think that all the above, the 3 cancers, are also caused by HPV. We have minorities thinking that it's either one of the cancers. Thank you. Stop sharing at this point and you can take it away.
Thank you so much. Yes, so this is just a reminder that HPV is a DNA virus, and it basically affects the lining of the cervix, vulva, vagina, and penis. It can also affect the lining of the anus. Then also, as earlier indicated, it is sexually transmitted. Then it is mostly asymptomatic and self-limiting, and thus that's why immune response is key on this point. Then also, as earlier indicated, it is the persistent infection that leads to cervical cancer. This slide we saw last week, and also we are just emphasizing for the high risk viruses. This slide is just meant to show HPV associated condition. You can look at it in details on the iEcho platform where the slides have been uploaded. then we see now when it comes to our previous 4 questions, we realize that the anus, the vagina, the penis, the vulva, oropharynx, the oral cavity, the cervix, HPV can cause cervical, can cause cancer in any of the organs that it affects. From here, you see that cervix, 99% of cervical cancer is caused or is associated with HPV, making it the single most important cause that we have. And thus, interventions should be targeted towards HPV. This graph just shows how, so you can see that there's the blue and the green color. The blue shows the number of cancers caused or associated with HPV, whereas the combination of the blue and green shows the total number of cases. So you can see on the cervix, barely you don't even see any green. This shows why HPV infection is very important in us addressing cervical cancer. You can see it has got a good share on anal, vulva, penile, as well as the oropharynx. But more importantly is on its association with cervical cancer. I will move to objective 3, where we want to talk about the 90-70-90 elimination goal. Over to you, Dr. Muhuma.
All right, third question, and it has been launched, single choice.
You can move to the other one. This was the first.
Yeah, this one looks different. Okay. I think this one has been repeated. Question 1 and question 3 are the same one.
Okay.
So yeah, you can just read through the question so that people can get to maybe even use the chat box.
Yeah, sure. You can use the chat box according to the mathematical model applied in the cancer elimination strategy. What is the projected impact of meeting the 90-70-90 targets by 2030 in low middle income countries on cervical cancer deaths by 2120? 1A is over 1 million deaths will occur. Cervical cancer deaths will remain unchanged. Over 10 million cancer deaths will be prevented, and over 62 million cancer deaths will be prevented. So you can just type the responses in the chat in view of time. Yeah, to remind ourselves, is about 2.5 years or so ago, the WHO developed what was called the global strategy to accelerate the elimination of cervical cancer as a public health problem. And also, this is where the 90-70-90 targets were formulated, and also with a target of reaching a threshold of less than 4 cases per 100,000 women developing cervical cancer. This is what will be called elimination. I think so far only one country has reached that threshold, and that is Australia, because of their vast immunization program. This slide you saw last week, it's an extract of the elimination strategy, where the first 90 is about vaccinating our girls by the age of 15. I think you saw the policies, the changes that we have gone through as a country with regards to HPV vaccination. In last week's presentation, where we started with the 14-year-olds, then now we have moved to the multi. Can you see my slide?
We have lost your slides.
Okay, just a second. I've lost it too. Okay. Share. Is it back?
Yes.
Yeah, sorry for that. Yeah, where we saw from last week's presentation that now the country has adopted the multi-age cohort where we are vaccinating 9 to 14-year-olds. And instead of the initial 2 doses that we are giving when we started the program, we will now be given a single dose because science has shown that even a single dose is effective for adolescent girls that are not living with HIV. And for those that are living with HIV, we will continue to give them the 3 doses. And today's topic focuses around the 70%. This is where we anticipate to screen our women, eligible women, at least twice using an HPV test in their lifetime, one by the age of 35 and the second one by the age of 45. Then the final 90 primarily looks at the treatment of precancerous lesions as well as invasive cancer up to 90%. So this slide basically highlights the mathematical model that was applied. And we are told that cervical cancer incidence rates are going to decline by 42% by 2045 and by 97% by 2120. And this will avert about 74 million new cancer cases. Remember, this will only work, we'll only be able to achieve this if by 2030, which is about 6 years from now, we would have reached the 90 targets and sustain these targets. And we are told that by 2030, we are going to decrease the number of deaths. About 300,000 deaths will be prevented. Then by 2120, we are going to prevent over 62 million deaths if we achieve the 90 targets. And what progress have we made as a country with regards to HPV testing? I think there was a question earlier on around HPV. It's delighting to know that we completed our first national guidelines for HPV integration in the cervical cancer program. Then also, in as much as the current focus is on HPV, it's on women that are living with HIV. This is a service that is being provided to both women living with HIV and those that are not living with HIV. Then so far we have activated approximately 6 sites per province to test using the HPV, using GeneXpert to test for HPV. Then initially when the program started, the distribution of reagents was through various implementing partners. But as of this year, all the distribution is done through ZAMSA so that the whole country can draw the reagents for HPV testing. So these are the targets that we had set for ourselves from last year, where the focus was on women living with HIV. We also have the targets for women that do not have HIV, but for the purposes of this presentation, we're just focusing on those that are living with HIV. We did estimate that by 2030, we should test at least 500 and 50,000 women who are living with HIV. We should screen them by HPV testing. So last year, of our target of about 120,000, we only screened about 33% with the HPV, of which the positivity rate was about 33%. Then also this year, as of June, we are standing at 21% achievement of the 130,000 target of women living with HIV. But of note is we see that the positivity rate is around 33% in terms of HPV. And also, this shows a very huge reduction to the baseline information that we had when Professor Paham et al. Did the initial study, which was indicating about over 80%. So this shows a remarkable reduction in HPV prevalence in women that are living with HIV, probably because of the advent of ARVs. And finally, we'll look at why QI projects are important in cervical cancer screening. I will not go deep into QI projects, but I just want to highlight key aspects that QI projects are able to help us detect early and also provide treatment of our women that we are seeing as evidenced by the presentation from Chilonga. Then also it gives us a chance to optimize the screening guidelines, as we saw from the discussions, the issues of bringing up HPV testing were coming out. Then also QI projects help improve follow-up and reflows. I think this was adequately covered from the first presentation from Chilonga, and also the questions that were coming from the audience. Then also, it also gives us an opportunity to actually engage the patients or the clients, as you saw in the case of Chilonga, where they had to do a mini survey, engaging the patients to try to understand what were the key barriers for the women to receive cervical cancer screening. So this makes QI projects important. And finally, I just want to show one activity that we did for the Muhuma hospitals. This was last year. So what you see is how the project, the USAID Zambia Accessible Markets, together with the Muhuma Hospital. You see the dark line shows the number of women that were screened. The red line just shows the number of women that we are supposed to screen at each particular point. You'll see that we're off the target until June 2023, until after a QI activity was introduced that understood the root cause analysis, and interventions were provided, and you see how the graph just went up to meet all the women that were in need of this life-saving intervention. Therefore, this just underscores the importance of QI projects in ensuring that we meet the right population. And I also just want to show you how the hospital has performed this year. You can see the blue line again represents the performance in regarding to meeting the key population, who are the women living with HIV. You'll see that this entire year, the hospital has been on track. This shows that when QI projects are well implemented, they can bring about sustainability in the way the service is being provided. And as such, this helps improve survival of our women, because if they are found to have lesions, we'll be able to treat them, or if they have got cancer, we'll be able to find it in the early stages and refer them for treatment. So this underscores the importance of QI projects, as you saw from the Chilonga presentation as well. So in summary, we need to remember that cervical cancer is preventable. We have the 90, 70, 90 targets. We just need to align our programming towards those. Vaccination is key. We have now moved to the multi-age cohort. We need to ensure that we support our communities, our hospitals, to ensure that vaccination is integrated. Then also, as we talk about preventing cervical cancer, we need to remember the second 70, where we need to start migrating from VIA to HPV testing. And we are taught we just need to have, a woman needs to have 2 tests, one by 35 and the other one by 45. It should be adequate to protect this woman from cervical cancer. And just underscoring what Chilonga presented, the slides I showed about Mupani, that QI projects can actually improve and sustain cervical cancer screening. In conclusion, I'm just going to quote Dr. Tedros, who is WHO Director General, where he says, through cost-effective, evidence-based interventions, including human papillomavirus vaccination of girls, screening and treatment of cancerous lesions, and improving access to diagnosis and treatment of invasive cancers, we can eliminate cervical cancer as a public health problem and make it a disease of the past. Thank you so much.
Thank you so much, Dr. Chaila. I thought you were going to read the full name, the Director General, WHO. We all
I wish I could.
Yeah. No, thank you so much, Dr. Chaila. This was a very eye-opening presentation, especially for me. And I can see from the comments in the chat box, people really enjoyed this presentation. So thank you so much for coming through. We can't thank you enough. And of course, we'll be calling on you again to go through such a wonderful presentation. Team Chilonga, that was a really good case presentation. Because of time constraints, I will just ask for the last comments from Team Chilonga and then from you, Dr. Chaila. Team Chilonga, Farrai and the team, did you find the comments in the chat box helpful going forward regarding your question about strategies that can be used at the hospital to sustain the positive gains? Because I think you've done a really wonderful job, moving from 60% to the high 90s. Farrai, did you get any actionable advice? Is Team Chilonga still connected? Farrai and the team? I don't see them on. So, Dr. Chaila, your last comments, please.
Thank you so much, Dr. Muhuma, for the opportunity. And I think my final comments will be focusing on what Dr. Tedros said. I think HPV, cervical cancer is preventable. And especially now with all the resources, with all the science that the world has developed, that Zambia has developed, has acquired, I think it's unfair for our women to continue dying of a preventable disease such as cervical cancer. As you saw, that the 90, 70, 90 targets will only eliminate cervical cancer in 2120 as a public health problem. I think all of us in this room, we will certainly not be alive at that particular time, but the rigors that we can share or that we can achieve as this generation is for us to make sure that by 2030, which is basically 6 years from now, we are able to achieve the 90, 70, 90 targets and also develop interventions that will ensure sustainability of these interventions beyond 2030 as well as beyond our lifetime. So it's a challenge to all of us. It is our rigors, it is within our reach for us to ensure that by 2030, the 90, 70, 90 strategy is achieved and we come up with interventions that will sustain those interventions. Thank you so much.
Thank you so much, Dr. Chaila, for that presentation. Very spot on, and a lot of people are just, singing praises. Excellent presentation from Petauke, from Isoka, from Winilunga, and Chama, as well as Lusaka. So thank you so much for the presentation. We want to also extend our gratitude to Madam Nomsa Siamwanza from JPIGO for putting up this, this work in the background. There were a lot of meetings that happened for this presentation to be made possible. And we are happy that it went well and people have found value in this presentation. So thank you so much. And dear network, we apologize for going over time by 7 minutes, but we thank you for bearing with us. Seeing that our time is up, we were looking at cervical cancer and HIV and the QA process. So we thank you for being with us from the start to the finish, for those that have been with us. And for those that joined us a little later, remember that this presentation will be made available on various WhatsApp platforms. This recording is also available on our YouTube channel, the MOH Echo YouTube channel. Please do check it out for the other presentations that you may have missed. My name is Malilwe Muhuma from the Lusaka Provincial Health Office. We are signing out now. Thank you and have a pleasant rest of the week. Thank you.
Thank you. Bye-bye. Nice session.